Good morning. Welcome to In the Trenches with DAC. This morning's topic is going to be nephrotic syndrome. So this is a condition that we see in the arena of internal medicine. How do you define this? You have nephrotic range proteinuria, which classically it's greater than 3.5 grams in 24 hours. Sometimes they use greater than 3 grams 24 hours. Decreased albumin, less than 2.5. Edema, and hyperlipidemia. That's nephrotic syndrome. The first point I want to make is distinguishing this from nephritic syndrome. Sometimes people get them confused. Nephritic syndrome, you have proteinuria, but it's not nephrotic range. You have hematuria, red blood cell casts in the urine, indicative of glomerular pathology. The blood pressure is elevated, and normally the creatinine is elevated, and you really have something called rapidly progressive glomerulonephritis. So these are different. Nephrotic syndrome could be more indolent. Nephritic syndrome is more acute. With nephritic syndrome, or RPGN, you don't have the nephrotic range proteinuria, the nephrotic syndrome, but if you look at urinalysis, you're going to see a lot of red cells and red blood cell casts. And these patients could be on their way to acute renal failure and possibly even chronic kidney disease. So let's talk a little bit about nephrotic syndrome. So they present with edema, and it's like anosarca. When these people wake up and they're lying flat, they could get periorbital fullness, a puffy face, proptosis of their eyes. This you usually don't see with other fluid overload states like CHF. Then when they're standing during the day, it gravitates to the legs. But the edema is significant. You could do a spot urine protein creatinine ratio. That'll give you an estimate of whether they have nephrotic range proteinuria. And their albumin is low because they're urinating it out because of the glomerular pathology, and that's also going to contribute to their edema. Okay, why do they have hyperlipidemia? They have high triglycerides and high cholesterol because as the body compensates and you increase the synthesis of albumin, it's the same synthetic pathways that make VLDL cholesterol, which could convert to triglycerides and elevated cholesterol. So, what type of problems do these patients have? Well, they obviously have edema. They have increased lipids, and these people need to be on statins, and they could have CV events. Nephrotic syndrome is also very thrombophilic. Okay, they're going to lose antithrombin, they're going to put that in their urine, and they're going to have increased synthesis of other clotting factors. And these people are prone to DVTs and PEs, and another condition which could also cause pulmonary embolism, which we don't think about that much, is renal vein thrombosis. And if a patient, you diagnose this, you have to think of nephrotic syndrome causing this. The other thing, these people are prone to infection with encapsulated organisms because they're putting immunoglobulins in their urine. So they have increased infections with encapsulated organisms, and they need to make sure that they're vaccinated for pneumococcus encapsulated organisms. And they will also increase vitamin D in the urine, and they can be predisposed to osteoporosis and bone disease. So these are some of the problems with nephrotic syndrome. All right, so you diagnose a patient with nephrotic syndrome, you have to ask yourself, what's the etiology? What's causing it? And you really have to look at the pathology. And most of these patients wind up getting kidney biopsies. You can have minimal change disease, membranous GN, membranoproliferative GN, and focal segmental glomerular sclerosis. So let's talk about these. Minimal change disease is probably the most benign of the entities, and it's usually seen in children. And it can be treated with steroids and self-limited. In adults with this, one thing that could do this is Hodgkin's lymphoma. And actually, if you treat the lymphoma and it comes back, it could come back as nephrotic syndrome. The other thing, non-steroidals have been reported to do this. They normally cause hemodynamically mediated AKI related to inhibiting renal prostaglandins, but they could also do this. Okay, now, membranous GN is the most common type of cause of nephrotic syndrome in the Caucasian population. And it could be idiopathic. And with this, you get it, to diagnose this, you get an antiphospholipase A2 antibody. And then there's secondary causes. You can see a membranous GN with diabetes. You can see it with lupus. This is one of the forms of lupus nephritis. Okay, you can see this with hepatitis B, much greater than hepatitis C. Normally membranous you see with hepatitis B. And you can see this with malignancies, and this might, idiopathic, especially an older person, you have to think of this, most likely adeno-CAs of the GI tract. And then they've reported this with certain medicines, and these were meds that we used more in the 80s. Captopril, which was the first ACE inhibitor, penicillamine gold used to be used for rheumatoid arthritis and so if you have somebody, and the way you're going to diagnose this is by kidney biopsy. Meds, Captopril gold. These meds on you. You're going to get an antiphospholipase A2 antibody. And if that's negative, you're going to evaluate for lupus. And you're going to, in certain instances, look for malignancy. Membranoproliferative GN, this could cause nephrotic or nephritic syndrome. And they kind of reclassified this. This is usually not idiopathic anymore. So you have really type 1 and type 2. Type 1 is immune complex mediated. And the big player here is hepatitis C. So somebody with membranoproliferative GN, you have to assess them for hepatitis C. You could also see this with lupus also. Okay, that's type 1. You have low complement, and you have immunoglobulin mediated. Okay, and type 2 is you have an abnormality of the alternative complement pathway. Okay, and they have low complement levels, but it's not antibody mediated. These diseases, atypical hemolytic uremic syndrome, C3 nephropathy, and type 2 membranoproliferative GN involving alternative complement pathway. Now, focal segmental glomerular sclerosis is the most common cause of nephrotic syndrome in African American patients. And often these people have a gene called the ApoL1. Okay, it could be idiopathic. You could also see this with IV drug addicts, IV drug abuse. HIV nephropathy could do this. Here, the glomeruli are ballooned. It's a little different. And the same pathology they've seen with COVID nephropathy. You could see this with obesity. You can see it with GU reflux, congenital abnormality. So this is something that it's not an uncommon. It's actually pretty aggressive. Okay, and the other condition you need to think of is amyloid, because that could present. And that comes under a category of diseases called monoclonal gammopathies of renal significance. There's amyloid light chain deposition disease. They're not multiple myeloma, but they're due to abnormalities of plasma cells, where you have monoclonal gammopathy. So this is what you have to think of. So if you're working a patient up for nephrotic syndrome and you make the diagnosis, there's certain blood tests you're going to get. Okay, you're going to get complement levels. If they're low, you think a membranoproliferative. You're probably going to get a hepatitis B and C profile, an ANA, although there should be other features of lupus, possibly an antiphospholipase A2 antibody, possibly serum-free light chains and protein studies, possibly an HIV, hepatitis C I talked about. So that's how you go about the diagnosis. And often these conditions are, you're not going to find out the cause, and you may need a renal biopsy. How are you going to treat them? They need to be diuresed. They clearly need to be diuresed. They need to be on vitamin D replacement. Usually they need statins. If they didn't have a blood clot, they don't need anticoagulation, but if they're in the hospital or any high-risk situation, you need to be very, very aware of this and make sure they're prophylaxed for VTE. And then with a lot of these conditions, you're going to use ACE inhibitors or ARBs to decompress the kidney and hopefully decrease proteinuria and delay progression of chronic kidney disease. And for some of these conditions, you would use immunosuppressive agents, be it Rituxan or Cytoxan or Cellcept, depending, what the cause is. If somebody has lupus with nephrotic syndrome, probably Cellcept. If it's really severe, maybe Cytoxan. If somebody has hepatitis C and membranoproliferative GN, you're going to treat the hepatitis C. If they have a malignancy, you're going to treat the malignancy. What should be known is, out of all these, membranous GN is the highest incidence of blood clots, and that's probably related to the fact that they cause the lowest albumin. So this is a quick talk on an approach to nephrotic syndrome, and we're going to stop right now. Okay, we're now out of